It is my honor to introduce today's speaker, Dr. Nate Gordon. Dr. Gordon became an assistant professor at EVMS in the Department of Sleep Medicine in August of 2023. He earned a Bachelor of Science in Biology from Virginia Commonwealth University in Richmond. He went on to attend medical school at Eastern Virginia Medical School, graduating with his medical degree in 2015. He completed his residency in family medicine at Fort Belvoir Community Hospital in Fort Belvoir, Virginia. He graduated as chief resident from the program. He chose to continue his training with a fellowship in sleep medicine at Walter Reed National Military Medical Center in Bethesda, Maryland. Dr. Gordon served as an active duty family and sleep medicine physician for the United States Army from 2015 to 2023. He won many awards during his tenure with the Army. Dr. Gordon is interested in all things related to sleep medicine. He particularly has emphasis on sleep disordered breathing, chronic insomnia, and restless leg syndrome. He feels his background in family medicine and primary care facilitates an interest in focusing on the patient as a whole, rather as a person with the condition to diagnose and treat. His research interests include identifying at-risk populations that are predisposed to sleep conditions that impair quality of life, personal and public safety, and wellness. He is an excellent educator and a clinician. Today, he'll be talking to us about Rest Easy this holiday season, an update on the management of restless leg syndrome. Over to you, Nate. Thank you so much for joining us.
Thank you. Can everybody hear me okay? Okay, good. All right, let me go ahead and shift gears here. So I have a slide on disclosures, and I don't really have any disclosures, but I will say the last time that I lectured this department, I was actually a third-year medical student. I was on Dr. Dixon's team. So it's pretty incredible that a little more than 10 years later, here I am getting to talk to you about something that I wouldn't consider a passion topic, but definitely something that we see a lot in the sleep medicine world and something that hopefully you may be seeing a lot in the internal medicine world as well. So let's get started. So as I said, I don't have any disclosures that are relevant to this discussion. And here's our objectives. We'll start with a clinical scenario as we normally would. And so the clinical scenario is a 65-year-old female. She's Caucasian and she's a retired floor nurse. She presents complaining with difficulty falling asleep as well as difficulty with returning to sleep several nights a week. Upon further questioning, the patient indicates that she has difficulty with uncomfortable leg sensations, and she kind of has a hard time describing what those leg sensations are, but she does state that rubbing her legs or feeling the need to move them often occurs, and this happens also during long car rides. Her partner happens to join her in the office, and he jokingly states that she's the house ghost because she walks the halls of the home at night when she's not sleeping. And at that point, the patient becomes frustrated, she becomes upset, she also becomes tearful, and she states that she hasn't slept well in years. And this has affected her ability to remain active despite being retired from being a floor nurse. And this scenario is something that's very similar to what's happened in my clinic. So some further information, her REO systems are relatively unremarkable. She does have a positive PHQ-2, but her PHQ-9 is 5. She indicates that she goes to the bathroom and urinates once a night when she wakes up. She has a past medical history that's notable for hypothyroidism, chronic intermittent back pain. She sees a physical therapist for that. She's undergoing orthopedic consultation. She has a history of depression, and she's previously been on fluoxetine, but that was discontinued 2 years ago. And she does have a history of documented insomnia. She's had a tonsillectomy and adenoidectomy as a child, and she did undergo a Roux-en-Y gastric bypass 10 years ago. Family history, relatively unremarkable other than your typical type 2 diabetes, hypertension, insomnia in her mother as well as her sister. Her father's history is unknown, and she takes levothyroxine, a bariatric multivitamin, a B12 complex, Tylenol, methocarbamol, and diphenhydramine as needed. Her exam, I'll just summarize for you, is relatively unremarkable. She has a BMI of 25. And you go through and do your full exam and you find nothing exciting. You diligently check the chart and you find that she had recent labs to include a CBC, a BMP, HIV, RPR, folate. All of these things are within normal limits. You do see that about 6 months ago, she was given a consult for behavioral health, but she chose not to activate it. You do see that in the chart, there's a history of hospitalization for symptomatic anemia, but that was a long time ago. And you do see that at some point she may have been taking some medications for a complaint of leg pain, but those were discontinued shortly after their first round of prescription. So this is meant to be more of a rhetorical question, especially for the learners in the room, residents and otherwise. What are you going to do about this? Are you going to order labs? And if you are, which ones? Are you going to recommend that you consult behavioral health? She does have a positive PHQ. Are you going to order a sleep study and consult sleep medicine? You hear that there's a new sleep medicine attending who needs plenty of patients, so you want to send her our way. Are you going to recommend a medication, and if so, what? Or are you going to ask more questions? So just rhetorically think about that. And while we do that, let's go ahead and transition to just talking briefly about restless leg syndrome and the history. So restless leg is also called Willis-Ekbom disease, and the Willis is referring to the famous English physician, Thomas Willis, who is known for the circle of Willis that you all may recall from anatomy. He was also the first to describe RLS. And so I'm going to get closer because I do think reading this quote is important. So he described restless leg as, wherefore to some, when being in bed, they betake themselves to sleep, presently in the arms and their legs, leapings and contractions of tendons, and so great a restlessness and tossings of their members ensue, that the diseased are no longer able to sleep than if they were in the greatest place of torture. And so I'm not usually someone who likes to quote people, especially in a medical lecture, but the last bit, particularly the greatest place of torture, is I think particularly relevant. I've had patients in my office with this condition describe restless leg in those exact words. So it's definitely something worth considering. Carl Axel Ekbom, he is the other clinician to refer to. And so he was a Swedish neurologist who actually coined the term restless leg and described its clinical features in 1945. And in Europe today, restless leg is known as Ekbom syndrome. So let's talk a little bit about the epidemiology and risk factors for it. Epidemiology, so it does affect all ages. It is clinically significant in 2 to 3% of adults. It is present in children in up to 1%. It's thought to be higher in Northern European heritage individuals. However, that may be due to underreporting in other ethnicities. And so the jury's still out on that. When the patients are greater than 35, women are almost always affected twice as often as men. And so in terms of risk factors, the big takeaways to consider here would be a history or a diagnosis of iron deficiency. And this has been shown, we'll talk about this a couple of times, but this has been shown in a variety of ways. When you test the CSF ferritin in individuals who have restless leg, you'll find that they have less ferritin present. Also, interestingly, when you do MRI in patients with restless leg, you'll find that they have reduced iron stores in the structures that are listed. And we also see restless leg commonly in conditions in which iron deficiency is present, such as renal disease and pregnancy. There is a strong prevalence of family history for restless leg, in mostly an autosomal dominant fashion. And so there's definitely some utility there in asking about a family history of difficulty with sleeping, insomnia, or specifically restless leg. There is some consideration for an increased incidence in folks who have rheumatic disease, as well as some consideration in those who have Parkinson's disease. All right, so let's shift gears and talk about the clinical features and diagnosis. So the big takeaway here, I won't read them to you, but clinical features specifically can best be remembered by this urge mnemonic. And so the urge to move your legs, resting precipitating your symptoms, getting up seems to improve the symptoms, or an evening prominence of symptoms is important to remember. And it turns out that this was first published and really discussed by the International Restless Leg Syndrome Study Group. And this is their diagnostic criteria. And essentially, it matches exactly what we just mentioned. The only discrepancy is that they do ask that it also not be solely accounted for by another medical condition or behavioral condition. So remembering that urge mnemonic is best. There are several RLS mimickers that I've listed here. Nocturnal leg cramps are the big one. Varicose veins and venous stasis is another common one. Peripheral neuropathy, especially for our patients who have type 2 diabetes. Leg edema, especially early presentation of leg edema, is not uncommon. And some of the others that we've listed here. A brief moment to discuss nocturnal leg cramps. So this is something that is distinct from restless leg. I only mention it because it commonly comes up in the sleep medicine clinic. This is when a patient would report experiencing involuntary muscle contractions that's usually associated with the foot or calf. It's due to hyperexcitability of their motor axons, and it's usually related to a situation where the patient has experienced repetitive lower extremity stress. So they, recently increased their walking to become physically more active with the new year coming. They had, to help move their child, from one location to another. These are some of the common things that we've heard. There are medications, obviously, that also can implicate electrolyte disturbances that can contribute to nocturnal leg cramps. Usually a treatment is to remove the offending agent, to consider stretching before and during the cramps. And there is some limited evidence for supplements, specifically the ones listed, as well as calcium channel blockers and gabapentin. So again, we're not talking about nocturnal leg cramps, something that's different. What about periodic leg movements of sleep or limb movements of sleep? And so this is something that we often see as indicated as a synonymous condition, and it's not. Periodic limb movements of sleep is purely a finding on sleep study where the patient happens to be moving their legs during sleep. It doesn't necessarily indicate that the person has a sleep disorder either. If they don't have any symptoms that are affecting their daytime function or disrupting their sleep, it's not considered a disorder. It's just a finding. And many patients who have restless leg may also have periodic limb movements, but many patients who happen to have incidental periodic limb movements may not clinically meet the criteria for restless leg. All right, so back to restless leg. Here's some interesting ways that patients may describe their symptoms, and I've probably heard the majority of these at this point. And I've only been doing sleep medicine for about 5 years now. So the need to move is definitely a big one. That's in our urge mnemonic. Crawling sensation, tingling, restless, cramping, creeping, pulling, painful, which is sort of a unique one, but I have heard. An electric type of sensation, tension type sensation, discomfort, or itching. There is a scale that you can use that's called the International Restless Leg Scale. I find that it's particularly useful for tracking RLS symptoms over time in response to treatment. And it is a trademarked or I guess a licensed scale. So if you're going to use it, you'd have to ask for permission, but the QR code that's in the slide will allow you to use it for free. You just have to sign up for it. So what about the consequences of restless leg? The biggest ones that we tend to see are insomnia, particularly sleep onset and sleep maintenance insomnia. It is not uncommon, however, for patients who, once they fall asleep, to experience awakenings at night. Untreated restless leg often begets mood disorder type symptoms, especially when a patient isn't sleeping well. And so depression and anxiety is not uncommon. And you can see restless leg symptoms in the arms, actually, in severe cases of restless leg, or in other cases of augmentation, which we'll talk about what that is in a minute. There are some exacerbating things to consider, and this is why taking a good history is very important. A lot of times patients who have restless leg don't sleep well, and so what does a patient do when they can't sleep well? They go to their Target or local pharmacy and pick up Benadryl or Tylenol PM or something that has the ability to help them sleep. And it turns out that those medicines can actually exacerbate restless leg. If you didn't know, restless leg is a condition in which dopamine is being affected. And so dopamine antagonists, specifically antipsychotics and antiemetics, can be strongly associated with restless leg symptoms. And so the Reglan and the chlorpromazine that you may be giving your patient to treat nausea may be triggering severe restless leg symptoms. And then some antidepressants have been implicated as well in contributing to restless leg, all with the exception of bupropion and doxepin. All right, so workup. We're gonna take a good history. We're gonna consider our urge mnemonic. Every patient that you suspect has restless leg should undergo at some point iron studies, and specifically we'll lay those out: a ferritin, a serum iron, and a TIBC. And the purpose of that is so that you can calculate your iron saturation. So every patient that you suspect restless leg in, I would strongly encourage you to go ahead and order those labs. A couple of bits. The first is that we want to ask those patients not necessarily to fast, but at least to avoid iron-rich foods 24 hours before that lab is completed, because we want to know what their ferritin level is from that person. We don't want to know what the ferritin level is from the steak or the burger that they just ate. It's also important to note that the normal reference range that often is listed for ferritin is quite low compared to what we as sleep doctors want to see a ferritin goal of. And so 75 nanograms per milliliter or higher is sort of what we're aiming for. But commonly, the lab value reference range will indicate that like a ferritin of 18 or 14 or greater is considered normal. So if you're someone who's paying attention to the red versus the red highlighted labs, you may miss this. In general, sleep studies are not required for diagnosing restless leg. It's a clinical diagnosis. However, you should consider sleep study if the person has symptoms that are concerning for obstructive sleep apnea or periodic limb movements. You should consider ordering some other labs if you haven't seen recent labs, to include B12 folate, A1C, vitamin D, thyroid studies, etc. And if it's clinically relevant, you could consider ordering EMG or other imaging. But again, think back to the history and start with the items that we've highlighted above. So we've talked a lot about iron and why is iron and restless leg important. And so we'll briefly mention that brain iron deficiency has been associated with restless leg. As we mentioned, it's been demonstrated on imaging before. And the hypothesis is that it's related to iron being a cofactor for tyrosine hydroxylase, which is a rate-limiting enzyme in dopamine production. And so if this is a disease of dopamine, then iron being deficient could implicate a contributing factor here. And so again, conditions with systemic iron deficiency certainly are associated with restless leg. Having a ferritin of less than 45 is associated with an increased severity of restless leg. And we also may be able to explain that nocturnal prevalence of restless leg, because as serum iron tends to drop at night, that's usually potentially associated with red blood cell production at that point. There's a couple of other theories as well. All right, so shifting gears to perhaps the bulk of the talk, and probably one of the most exciting bits about this topic that has really developed in recent years, and why I wanted to bring this to the department's attention, is that there have been updated guidelines, the first in 12 years, from the American Academy of Sleep Medicine regarding the treatment recommendations for new diagnosis restless leg patients. And so maybe about a year or two ago, the Mayo had published some updated guidelines, and it took some time for the American Academy of Sleep Medicine, approximately 5 years or so, for their task force to review and publish an updated set of guidelines. They went ahead as a team and reviewed about 1,500 clinical trials. They simplified the recommendations for a strong or conditional for or against in terms of treatments. And they did recommend some major practice changes that I think are going to change the way that you treat restless leg moving forward. First-line treatment now includes IV iron, alpha-2 delta ligand calcium channel blockers, and probably the big foot stomper in the room is that there's now a conditional against recommendation for dopamine agonists. And so you may be thinking, well, that's what I've been treating all my RLS patients with, or you just said that this is a condition of dopamine problem, so why would we take that away? And we'll talk a little bit about that. So of course, firstly, like anything in medicine, you want to address any factors that may be contributing. And so alcohol, caffeine definitely are contributing social factors that may be implicated in restless leg. I'm not saying that every restless leg patient has to go dry or give up their Starbucks, but certainly it is worth a trial. And good luck. They usually are very particular about that. Medications wise, we've already talked about some of those reasons and some of those medicines to consider avoiding, evaluating for OSA, and then also considering poor sleep habits. It turns out that folks with restless leg who aren't sleeping well are going to often experience more restless leg symptoms. And so trying to work through some of those sleep scheduling or sleep behaviors is going to be worthwhile. All right, let's just jump right into it. The big stickler in the room here, dopamine agonists. So that would include pramipexole, ropinirole, rotigotine, and levodopa. For the last 20, possibly 30 years, this has been the standard for treatment. These medicines directly stimulate dopamine receptors. However, they also can contribute to something called iatrogenic augmentation. And so what that specifically is a condition in which the symptoms that previously were present are now showing up earlier in the day with worse severity compared to baseline. And taking a dopamine agonist confers a risk of about 8 to 10% per year in terms of developing this condition of augmentation. And so it's a dose-dependent response. It is associated more commonly with medications, levodopa, ropinirole, followed by pramipexole and rotigotine. So rotigotine is the transdermal long-acting patch, and so that seems to be less implicated. However, it is one of those things where you could still see augmentation occurring. And in general, as we remove dopamine agonists from the treatment plan, if you were to abruptly stop it, you would see a rebound of those restless leg symptoms in a very, very significant degree. And so it's a difficult thing for us to sort of, I think, shift gears. Change is often somewhat challenging for us to accept. But what's been shown over time is that if we're hurting our patients by temporarily treating their symptoms, this is not the route that we should go. And unfortunately, the first few studies that led to the FDA approval of these medications were about 3-4 month trials. And what's interesting about that is restless leg is often a condition for life. It's not only going to be treated for 3 to 4 months. And so a lot of times the tail ends of the trials were missing the fact that patients were perhaps beginning to augment or experiencing augmentation some months or years later. All right, so we'll come back around to augmentation in a little bit, but again, going forward with the guideline recommendations, IV ferric carboxymaltose, or specifically that's a specific form of IV iron, is given a strong 4 as a first-line recommendation. And so oral or IV iron is indicated if a serum ferritin is less than 75 or the transferrin saturation is less than 20%. And so the way that I would recommend and the way the guidelines recommend dosing oral iron, if they meet that criteria, is 325 milligrams every other day with a vitamin C source and avoiding calcium-rich foods at the time of intake. And so if that's something you're not counseling your iron, supplementing patients, they may be taking that iron supplement with a glass of milk, which isn't really doing the job. IV iron alone is indicated specifically for individuals who have a serum ferritin of 75 to 100 micrograms per liter. And the reason why is because hepcidin downregulates oral iron absorption. And so the oral iron that may be taken may not actually get absorbed. IV iron is also preferable in patients who have malabsorptive conditions, chronic inflammatory conditions, intolerance complaints, difficulty with symptoms despite taking oral iron, or a need for rapid response. And so probably the biggest issue here is going to be getting the patients approved for IV iron, as well as the logistics. But in general, we're trying to shift gears and focus with iron first. The alpha-2 delta ligand calcium channel blockers also received a strong 4 recommendation, and that includes gabapentin, enocarbil, and pregabalin. They are thought to decrease glutamate release, which is helpful in this condition. They are not associated with augmentation, but they do have a variety of side effects that are listed to include somnolence and dizziness. And only gabapentin enocarbil is actually FDA approved for RLS. Here's some dosing strategies. And the reason why I actually really just want to focus on gabapentin here is because it's not uncommon for patients to get up to an effective dose of, say, 1,200 to 1,800 milligrams of gabapentin. However, what you may not know is that gabapentin is poorly absorbed by the gastrointestinal tract. And so in patients who require these high doses, you may want to consider splitting your dosing regimen so that they can better absorb the medication. And I'll show you an example of that. So this is a relatively old graph from a paper that was published in 1998 about the bioavailability of gabapentin. But the long story short and the takeaway is that absorption of gabapentin drops once doses begin to exceed 400 to 600 milligrams. And so in most cases, if a patient's taking 600 milligrams or 800 milligrams to get up to that effective dose, they may not really be getting much beyond 400 milligrams or less. And so the idea is that split dosing when symptoms are most likely to occur is recommended. And so rather than having your patients who have restless leg symptoms only at night take their medicine 3 times a day, once in the morning, once in the middle of the day, and once in the evening, why not consider dosing that medication once at bedtime, once at dinner time and once at bedtime? Or if they do experience symptoms during the day, you could have them dose that in the middle of the day as well. But it's one of those things where the effect of gabapentin is only about 4 to 6 hours. And so you do want to try to time it based on their symptoms. This is a study looking at pregabalin as compared to pramipexole. And in a study of 719 patients, they were able to demonstrate that pramipexole and pregabalin were both superior to placebo. However, pregabalin was not associated with augmentation, and thus it should be preferred to the pramipexole and its other dopamine agonists. Gabapentin enocarbil is a relatively newer drug formulation of gabapentin. It's associated with improved pharmacokinetics for absorption, and it has been shown to improve its absorption rate with food. So this is just some data suggesting or showing improvements over time compared to placebo. So here's what I would consider to be a somewhat controversial topic. So low-dose opioids did receive a conditional 4 recommendation. And if you have patients who have refractory RLS or patients who are experiencing augmentation, I would encourage you to remain open-minded about low-dose opioids in a long-acting formulation as a potential treatment option. It's interesting that, over time, opioids rightfully have become something that we as prescribers have sort of shied away from, all for good reason. But at the same time, these are medicines that can be used in low formulations, low total morphine milligram equivalents, and generally speaking are shown to be effective for folks who have refractive RLS. It's not uncommon for folks who have either augmentation or restless leg symptoms that are persisting for 6, 8, maybe even 10 hours a day to perceive and receive improvement from a low-dose medication such as methadone. And so if you have a patient who's struggling to come off of a dopamine agonist because they're augmenting, and you're using something like gabapentin or gabapentin enacarbil or pregabalin, low-dose opioids may be the next step in that treatment algorithm. And that's something that sleep medicine would be willing to help you with. So I would recommend, and the guidelines would recommend, that you base your decision on which opioid based on the duration of symptoms. And so in the previous slide, I had listed out some, if patients have, let's see, we'll go back. If patients have 6 to 8 hours of symptoms, considering something like low-dose oxycodone ER, versus if someone's having symptoms 10 to 12 hours a day, considering something like methadone or buprenorphine. These are very, very low doses in MMEs compared to those who are utilizing opioids for opioid use disorder. Buprenorphine, interestingly, has a ceiling effect, which does not associate an increased risk of respiratory depression. Methadone, one quick tidbit about that, can prolong QTC, so you want to check that. And then, of course, if you're going to start a medicine like an opioid, we do this in the sleep medicine clinic. We would check the PMP. We would sign a pain contract with that person. We would use a urine drug screen as needed, usually once annually, and then consider an opioid risk tool assessment to see if that person is at risk for when they use an opioid. So this is definitely, a shift compared to what we are traditionally being taught and sort of guided as far as opioid use. A new kid on the block, something that is super new, I haven't even seen one in person yet, is the perineal nerve stimulator, which received a conditional 4. And essentially what it is a electrical stimulation device that goes over the leg bilaterally and stimulates the perineal nerve for up to 30 minutes, 4 times a day. What's interesting is compared to sham devices, the device was capable in reducing restless leg symptoms in a significant degree, and with it was able to receive FDA approval within the last few years. The device is fairly new, but it is a good option for folks who are either on higher dose of medications or for folks who may be augmenting, because they could use this at all times of the day without experiencing side effects associated with their medicines. It also may be useful for those individuals who experience symptoms in the middle of the night. And so if you don't want that person to redose what otherwise would have been a dopamine agonist or another dose of gabapentin or even an opioid in the middle of the night, they may be able to use this device to help treat their symptoms in that moment. Sort of an interesting one that I was surprised to receive a conditional 4 recommendation was the antiplatelet medication dipyridamole. It's typically used in individuals who have peripheral vascular disease, and it was shown to significantly improve restless leg symptoms in one randomized controlled trial in 2021 that was conducted in Spain. There were some adverse side effects, but they were fairly minimal. And so as a result of this one study, a conditional 4 was recommended. So it does expand some of the options that we have in terms of treatment, but I have yet to prescribe it. And then back to the dopamine agonist. So in general, the main takeaway from this slide is that I'd like to emphasize the max doses here. And so pramipexole, if your patients are exceeding 0.75, ropinirole, if your patients are exceeding 4 milligrams, or rotigotine exceeding 3 milligrams, it's a high likelihood that your patients are probably experiencing augmentation. And with that may be an indication to, number one, have an honest conversation about that medicine, but then number two, start thinking about how we could manage that condition. So dopamine agonists are commonly associated with nausea, lightheadedness that often resolve. It is worth noting that dopamine agonists are associated with impulse control issues in about 6 to 17% of patients, which would include pathologic gambling, compulsive eating, shopping, and hypersexuality. Again, of course, we talked about augmentation. So how do you diagnose augmentation? How do you know that your patient is augmenting? And so typically it would be a situation where the patient's experiencing worsening symptoms as compared to baseline, And believe me, they'll be able to tell you that. They'll also, over time, indicate that their medication requirement has gone up. So it's not uncommon for those patients to state, well, we started at X dose, but I started taking an extra one because I was noticing my symptoms were coming earlier or worse. Typically, the symptoms will present earlier in the day, or even sometimes right after waking up in the morning. In severe cases, when the dopamine agonist is worn off, they can experience symptoms in their arms as well. So how do you manage it? Well, the first and probably most important thing to do is to not abruptly stop the medicine. If you do that, your patient will experience such significant restless leg rebound that they will have a very, very rough time. In fact, reducing doses are often recommended in no greater increment than about 10% over several weeks. And so it's a situation where the taper can take a very, very long time. All the while, I would recommend, and the guidelines would recommend, that you add a new medicine, such as an alpha-2 delta ligand or an opioid, while tapering it off. And so it's a situation where you add first and you subtract later. You take more time than you need to have that person taper off. At the same time, because you're doing this over a long period of time, it's important to consider checking iron studies and supplementing where needed. And if you need to, if let's say the patient's on levodopa or they're on rotigotine, or they're on not on rotigotine, any of the other medicines, you may consider switching them to rotigotine because that long-acting transdermal patch may be associated with fewer severity in terms of augmentation. Here's the rest of the medicines that were listed in the guideline, just so that they're there and present. You can see that clonazepam, one that is commonly utilized, is actually on the conditional against. And so that was sort of an interesting change. We use clonazepam for a lot of different things in sleep medicine. We don't really have great evidence for a lot of the things we use. But one of the biggest interesting points about clonazepam for a conditional against is that it has such a long half-life, and the symptoms tend to only occur for a few hours at night. So clonazepam would not be your first choice of medicine. All right, so with that, our take-home points, you're going to remember your urge mnemonic. You're going to keep in mind that restless leg is different than other conditions that you may have associated with, such as periodic limb movements and leg cramps. You're going to look at other exacerbating factors, such as their sleep quality and sleep practices, whether or not they have OSA, whether or not they drink a lot of alcohol or caffeine, their exercise. I didn't mention this, but exercise has been shown in a moderate degree to improve restless leg symptoms, but severe strenuous exercise like running a marathon may be known to trigger restless leg symptoms. You're going to make sure that every restless leg patient or patient you suspect restless leg is going to have an up-to-date ferritin, serum iron, and TIBC. And you're going to consider for first-line therapies alpha-2 delta ligands as well as IV iron and oral iron. You're going to be cautious about starting those individuals on dopamine agonists, and frankly, I would avoid it if you can. And then you're going to consider referring these patients who have refractory RLS, who may need a combination of therapy or low-dose opioids to a sleep physician. And so wrapping back around to our patients, what are you going to do in terms of labs? You would order a morning serum ferritin, iron, and TIBC. I wouldn't necessarily consult behavioral health at this time. Her PHQ-9 was 5, which is mildly elevated and may improve as you treat her restless leg symptoms. I wouldn't necessarily recommend ordering a sleep study, as we don't really have any other indications that she would have sleep apnea or another condition to screen with a sleep study. I would not necessarily recommend a medication for sleep at this time, as many can exacerbate restless leg symptoms. And I probably would ask more questions, particularly about her history of trigger medicines, whether or not she's ever been on opioids in the past, whether I would ask her a little bit more about that anemia history, and then also ask her about family history. And so with that, this is a summary table that you guys are welcome to take a picture of. There are some resources up in the top right-hand corner. RLS Curbside is a really great resource that you can actually register with an NPI and then get consults with restless leg patients anonymously with a variety of restless leg experts in the field. The Restless Leg Foundation is definitely something that I would recommend your patients to go to. Dr. Burkowski is one of the main authors for the clinical guideline update, and then my contact QR code is there on the right-hand side, and I'd be happy to entertain questions at this time. Thank you.
Thank you so much, Dr. Gordon. It was a wonderful update. The house is open for questions. In-person audience, if you have a question, please press and hold the microphone in front of you.
Hey, Paul. Could I ask you, please, do you have specific preferences and medication for elder population? Because I had a case a few years ago with a lady, 60 or 62 years old, and she was on pregabalin. And as I understand, 600s of pregabalin make her really high, and she fell down and broke her leg. So do you have specific preferences in medication that can improve safety in such patients?
Definitely. So for those that had a hard time hearing, I think my understanding of the question was preferences in terms of which medicines, if any, in terms of safety efficacy. And so I think in a general sense, it's a patient individualized approach in someone who perhaps has a fall history, cautiously proceeding with a medicine like pregabalin or gabapentin, and obviously starting at a low dose, as we know that there's a dose-dependent risk of falls and dizziness. In terms of what my preference would be, it would probably be first if the patient had any low iron on those studies, starting with iron and maybe just doing that alone. A lot of times you'll see that patients do respond to iron independently of any other medicines. And then at that point, if iron was not giving us the response that we wanted, then certainly based on the patient's risk profile, if you will, and looking at some of the other medications that they're on, going from there. But you're not wrong. The first line treatment medications, I think with the exception of IV iron, which sort of has some risk, but I think nowadays most IV iron is not necessarily associated with severe reactions. The other ones, the alpha-2 delta ligands, are not risk-free. And so just like anything, it's shared decision-making with lots and lots of patient safety counseling.
Thank you.
You're welcome.
Reese.
So I just had a question. If someone were to have both anemia of chronic disease and iron deficiency anemia, would you still consider giving IV iron in those cases for if they were having these symptoms?
Yeah, great point. So it's a situation where if it were a possibility and there were not a significant contraindication, as far as I know, there isn't a significant contraindication in those individuals who have anemia of chronic disease to supplement with either an oral or IV iron supplement. So assuming that there isn't, if their restless leg symptoms were severe enough, absolutely, yeah.
Any other questions? Yes, please, go ahead.
What about the drug bupropion? I saw it was on your list, Wellbutrin.
Yeah, so at the time of the guidelines being published, I don't believe bupropion was given a recommendation for. I want to say that it was recommended for the use for mood disorder treatment in individuals who have restless leg to avoid exacerbating restless leg symptoms, as do some of the other antidepressants. But for the purposes of treating restless leg, not so much. Mm-hmm. Good question.
Any other questions? Great. With this, we wrap up the grand rounds for today.
you.